Right, so welcome everyone to the March Liverpool Dementia and Aging Research Forum. It's a pleasure to have nearly 150 people registered for this webinar, so clearly people are really interested in hearing about hearing loss and Parkinson's disease and Lewy body dementia, and how hearing loss in particular is linked to those two subtypes of dementia. So today we have two fantastic speakers from different backgrounds, but both with the aim of improving the lives of people living with dementia. So we have Mark Oakley, who's a lead admiral nurse, joining us. Welcome, Mark. And we also have Dr. Megan Reedman, who is an NIHR Alzheimer's Society postdoctoral research fellow at the University of Liverpool. So we thought to start with, Mark is going to give a bit of an overview of what his work is like as an admiral nurse, and talking about Lewy body dementia in particular, and then we'll be followed by Megan's talk specifically on Lewy body and Parkinson's disease dementia and what hearing loss has to do with this. So we've tested out how to share the screen. Mark, would you like to start your talk and share your screen?
I will try to. Okay, I'm just going to try and share my screen with you all now. Can everybody see that?
Yeah, we can now see so we also see the next slides.
Oh, okay. I'm afraid I'm not very good with this Zoom thing. I'm afraid.
If you click on at the top, it says display settings. There's three options at the top of your screen. There is display settings. So a bit to the left and then higher up.
Display. Oh, I don't seem to. Oh, yes, I do. Yeah.
Yeah. If you click on that,
yeah.
it should be swap presenter view and slideshow. I think that should do the. Yeah,
okay.
There we go.
Okay. Okay, well, good afternoon, everybody. Apologies for my computer illiteracy. Thank you very much, Melissa, for inviting me. My name's Mark Oakley, and I'm proud to say that I'm a lead admiral nurse, which is a clinical nurse specialist for dementia based up in Wigan. And I cover Wigan, Wrightington and Lee NHS Foundation Trust. And I've been in post for coming up to 3 years. I'm also an ambassador for the Lewy Body Society and also John's campaign. So the Admiral Nurse Service was launched in October 2021 with the aim of supporting patients and carers and staff, importantly, living with a dementia diagnosis. And as you're probably all aware, there are around about 940,000, probably near to 1 million people living with a dementia diagnosis within the UK. And it is judged that it will go to over 2 million by 2050. And within my locality, there's about 4,000 people living with a dementia diagnosis. As an Admiral nurse, I work with people and families affected by all types of dementia using a family and relationship-centered approach. I'm an acute Admiral nurse, which means I work predominantly within a hospital. And we provide specialist assessments and evidence-based interventions. We use a clinical and psychological and social support for family and carers. And I think it's important to sort of point out that the nurses on the ward are absolutely fantastic in general at looking after the person living with a dementia diagnosis, and we get pulled in and get referrals for more complex issues around behaviours, transitions of care, acute confusion, agitation, etc. But a lot of our work is actually down to supporting the loved ones and the families, because they feel quite lost. And on many occasions, myself and my colleague Tracy have the thing about, it's great to finally have someone that will listen to us. We feel like we've been left in limbo. We feel like we're treading water or treading treacle. We liaise with other professionals and other organisations, internally and externally. We also provide education consultancy and supporting changes in practice within our trust. And importantly, we provide education for our hospital staff by providing tier 1 and tier 2 training for around dementia awareness. And we're currently developing tier 2 training around nutrition, end of life care, communications, etc. We go to a lot of best interest and discharge planning meetings to support families and advocate for the person living with dementia to ensure that they get the best outcome whilst taking into consideration what their needs may or may not have been. We assess patients without a confirmed dementia diagnosis, and we are lucky enough to have a great, it says LAMS there, but that's later life and memory service, who allow us to directly refer those patients who've come in with an undiagnosed cognitive decline or impairment to see whether or not there is actually a dementia diagnosis that's been not diagnosed. That obviously fits in with early diagnosis as set out by the government. We've also realised that we have raised our profile locally, and we get a lot of people using the telephone or emailing us to say, can you help us? But as I've said, we are an acute Admiral Nurse Service, which really means we should only be dealing with the in-hospital patients. But we don't like to say no to people. So we've actually got our own Admiral Nurse outpatient clinics, which we can invite community patients and their loved ones, or just their loved ones, in to have a little chat about what is going on and say, how can we help? We've now are able to do the virtual dementia experience training, which some people may know as the Dementia Bus. We went down to Colchester and did the trainer, and we can now do that for 2 years, and we're getting really great feedback from that. We offer guidance and support around transitions of care, both pre-admission and admission through the discharge and beyond. We're doing a lot of work at the moment for elective patients who have a dementia diagnosis, who sometimes may be missed, certainly through pre-op assessments, etc. And we've been working quite closely with one of our colleagues who's actually developed a living with dementia theatre passport to support those patients coming in who are having surgery. We support around effective and timely discharge, and we signpost and navigate to the right support, not only now, but I think importantly into the future as well. When I first set up the service, I was sort of getting a lot of people coming up to me and saying, Mark, can you help me? And these were staff members. But having sort of like discussions in a corridor isn't the most timely and most appropriate place. So we set up again little clinics for them, because I think it's important that we look after our staff, because if we don't look after our staff, how are they going to be best placed to look after our patients in hospital? So we're currently supporting about 20 staff within our trust who have a loved one or are caring for somebody living with a dementia diagnosis. We work with the ward's multidisciplinary teams to offer expert advice and support. And as an Admiral Cruise, we aim to create a seamless care pathway for patients with carers and families in hospitals, thus enabling that they get the right support delivered at the right time. To give you a brief overview, I just thought I'd show you what our workload was for last year. And within the 12 months, we had 1,488 referrals. And we broke those down into patients with confirmed diagnosis, those that we referred to the later life and memory service, the patients that came in without a diagnosis, but actually turned out to have a delirium as a primary diagnosis, and also those that we saw as being inappropriate. So as you can see, at least 51% of our work was appropriate. And we did quite a lot of work around referring patients to the memory service. Nationally, they state that Alzheimer's disease is the most common form of dementia around the country, which we all know is true. But as you can see from our data, it wasn't the most common within our locality. It was actually the third most common. But as you can see from there, we do have the less known ones. So we've had Lewy body dementia looks like 2%. Frontal temporal dementias, Korsakoff's, which is the potential alcohol related. But also we found that sometimes patients were discharged from the memory service with an unspecified type. and some of the things that we've done to make it better for our patients within hospital. I'm a bit of an old nurse. I trained back in the 80s, even though I know I don't look it. And we had lots of day rooms, and we were able to actually do a lot more interactive things. But I think it's also important to state that back in those days, patients weren't as sick, and we weren't getting as many people through the door. But with the advent of all those sort of things, we've lost day rooms and spaces like that. And sometimes our patients don't get any interaction at all. And it's quite important with the person living with dementia that we actually, interact with them, and we do things to try and keep them settled, orientated, and, giving them things to do. So the RITA system is reminiscence or rehabilitation and interactive therapy activities system. And it's a television screen which is preloaded with lots and lots of things: films, music, books, games, and lots of other things to do. We currently have 13 of those systems around our wards. And I've just applied for further funding for 6 more, so that it will mean that all areas within my trust, apart from paediatrics and midwifery, will have a RITA system. And it's been really greatly received, to the fact that the wards, when I go on there and I'm looking at it, they say, "You're not taking that away, are you?" No, we're not. A couple of things that we can say how it's worked. We've had patients that have been really, really agitated and non-compliant with care. We've used it to have music on in the background, or give them a film to watch, and all of a sudden you can see their agitation things coming down, and they've actively engaged with the nursing staff and with their care process. We had a gentleman that was due for discharge, and he was walking up and down the ward all over the place, which was his norm. And we took this RITA system into him, and there's something on it which allows you to do sort of painting, and it's all touch screen. So you get a picture, and then you get a paint palette at the bottom, and all you need to do is press the color paint and press on the screen. And when his wife came in to pick him up, she says, "Where is he?" Because she couldn't see him, and he was sitting down, and she thought we'd sedated him in some way because he never sits down. And then we said, "Well, no, we haven't done that. He's due to go home." And she said, "Well, what have you done?" So we showed her this, and about 2 weeks after he went home, I had a phone call from her thanking us for that, because she went into town and brought a load of stencils and paints, etc. And he would sit there for hours just painting, and it gave her the ability, as a loved one and a carer, to have a little bit of respite for herself and get on and do things, because she wasn't worried about where he was, what he was doing, her following her around, and sort of, as she put it, he seemed to get in the way. So it's been really greatly received. We've instigated in January of last year a therapy dog. So little Hetty there comes in with Barbara. Barbara happened to be one of our radiographers, and she retired, and she got the dog, and she wanted to give something back. So Hetty has got her own little timetable of coming into the wards every week. And again, she's been really greatly received on our wards. This is the virtual dementia experience, or the bus. We don't have a bus. We just get some rooms, but we've got nearly 200 of our staff through, and each and every one of them has had a better insight into what it might feel like for a very short period of time to lose all your cognitive things, and feel like what it might feel like to have a dementia. But unlike a person who has that diagnosis, once they take their headphones, their gloves and everything off, they're back to being who they were. We aim to sort of get around about 500 people through in 2 years. The wards, before we'd set up the service, there was no education or anything going on. Now each and every ward within our trust has a delirium education board and a dementia board, and they've also, in different areas, have got dementia care trays. In these 2 pictures, on the left, you've got, well, Jenny's in both of them, but Jenny's one of our healthcare assistants down in A&E, and she has made A&E a much better place for patients living with dementia to come into. And in the other photo is my work wife, Tracy, holding the dementia care tray. And again, it's just little things that we're able to do to help calm our patients down when they come in, because it's an alien environment and they don't know where they are, etc. And if we look at just simply going over the rarer forms of dementia, we tend to think of Lewy body dementia, dementia in Parkinson's disease, frontal temporal dementia. We now have a lot more we're getting with young onset dementias. And I think that's down to the fact that we are actually identifying patients earlier rather than sort of thinking it's nothing wrong. And obviously Korsakoff's. And this simply breaks it down into what we saw in 2023. So yeah, we had 135 patients with Alzheimer's, 138 with vascular, and 183 with mixed. But as you can see, Lewy body accounted for at least 12 admissions. Frontal temporal was 4. We had 6 Korsakoffs, and we had 10 with dementia in Parkinson's disease. And then there was that 37 which were unspecified. But that still equated to 6% of admissions with a confirmed diagnosis within my trust. And what we've done is we want patients not to be labelled. So we worked quite hard with the nurses and the medical teams to promote the umbrella of dementia. Okay, so the word dementia is an umbrella term for symptoms in like memory loss, confusion, personality changes, but it's also caused by a number of diseases. And we've actually worked really hard now, and we're seeing so many more patients coming in that actually have the diagnosis within their past medical history, which makes it a lot easier for us to sort of get a plan in place to ensure that we're looking after the person with the diagnosis properly, but also are looking out for the different symptoms under the different umbrella terms. And just basically to pull it all together, the aim is to ensure that hospital staff caring for patients living with dementia diagnosis are treated as individuals and not labelled, because historically in the hospital notes they would refer to the past medical history just as dementia. We're now getting that, seeing that specified type of dementia noted, and through education, staff are now better equipped to understand, how I didn't do that, to understand the differences between how a person may present. Thank you very much. I'm going to stop sharing my screen now.
Thank you so much, Mark. We will take questions afterwards, so we thought we'll have both presentations first. So over to you now, Megan, and if you can share your slides, I'll give you a talk.
Perfect. Can you see that okay, Clarissa? Brilliant.
Okay.
Thank you so much. So as Clarissa mentioned, I am Megan and I'm a postdoctoral research fellow at the University of Liverpool. And the project that I'm working on at the minute aims to look in more detail at the relationship between hearing loss and Parkinson's disease dementia and dementia with Lewy bodies. So what I thought I'd do today is just kind of explain a little bit more about this project and give you some preliminary findings that we're starting to see come through. So you may very well have seen over the past around about 10 years, there's been a lot of evidence to suggest that hearing loss may be a potentially modifiable risk factor for dementia. And what essentially that means is if somebody has a hearing impairment or a hearing loss, the likelihood that they go on to develop dementia may be increased. So we're seeing a ton of evidence supporting this. And in fact, in the Lancet commissioned report in 2020, the Jill Livingston report, it suggested that hearing loss, if we remove all cases of hearing loss that are potentially preventable, we could reduce dementia cases by 8%. So there is what appears to be quite a strong, quite a robust relationship between hearing loss and dementia. And why may this be? There are a couple of reasons why this may be, and the slides won't move, sorry. So it could be that both hearing loss and dementia have a common cause. So they both might be caused by the same neurological underlying facet. Or it may potentially be that when somebody has a hearing loss, it's more difficult to hear, right? So it's more difficult to process the information that you are receiving acoustically. So in these difficult situations, it may be that we have to take more of our cognitive resources to hearing and listening. And what this may lead to over a really long sustained period of time is that we have less resources available for cognitive functions. So less resources available for things like memory, planning, executive functions like that. Or alternatively, it could be that when people really struggle to hear, I'm sure we've all had a situation where, you've gone for a meal and you're sat on the end and it's really hard to follow the conversation. What happens in this circumstance is sometimes people withdraw from society. So they're struggling to communicate, they're struggling to engage in the conversation. So they withdraw from society and potentially become quite isolated. And this social isolation, we know, may potentially be a risk factor for dementia. So in becoming isolated, you're not engaging in cognitive functions, which then may lead to sustained long-term problems in terms of cognition. But what the problem is with all this evidence, and Mark has really quite nicely illustrated, is all these studies, basically what they do is they look at this massive database of, I don't know, 500,000 people in the UK. And then they do this complex statistical analysis that looks at whether hearing loss is a risk factor for all-cause dementia. So what they do at this point is lump every type of dementia together. And as Mark's really nicely explained, Alzheimer's disease dementia may account for up to 80% of those cases. So if we're looking at this database that says have 500,000 people who have who are in the database and say, I don't know, 50,000 of them are living with dementia, it could be that 80% of that 50,000 are living with Alzheimer's disease dementia. So when we do the statistical analysis, what we really don't know is whether the relationship is true for all types of dementia, or whether what we're actually looking at is just a relationship with Alzheimer's disease dementia. So that's the first issue that we're seeing there. In this body of literature, we don't really know if this is the case for all different types of dementia. So what we want to specifically look at here is hearing loss linked to dementia with Lewy bodies? So Parkinson's disease dementia and dementia with Lewy bodies. Just quickly to reflect on the slight nuanced differences between Parkinson's disease dementia and dementia with Lewy bodies. What we see is people who live with Parkinson's disease dementia and dementia with Lewy bodies may share a lot of the same symptoms. So they may both experience sort of motor complications, hallucinations, fluctuations in cognitive status. So they may share a lot of similar symptoms, but the main diagnostic difference would be what comes first. Is it the motor symptoms that come first that you typically associate with Parkinson's disease, such as tremor and rigidity? Or is it the more cognitive-based symptoms, such as the hallucinations and the fluctuation in cognitive status that comes first? So biochemically, there are differences. There are a lot of similarities, but there are also differences. But the main distinguishing factor in terms of diagnostic is what sort of comes first. So, as I've said, this project aims to investigate whether hearing loss increases the likelihood that an individual will go on to experience a Lewy body dementia, and also to understand the experience of hearing loss. So as I've said, most of the previous literature is very statistically driven. What we don't necessarily know too much about is the lived experience. So how is having a hearing loss whilst also having Lewy body dementia actually affecting people? Is it making anything more difficult? Is it changing anything in any way? At the minute, we're not too sure. So this is what I just wanted to show you a little bit about today. So we've been engaging in some interviews. We've been interviewing people who are currently living with both a Lewy body dementia and a hearing loss. And we're talking to them and asking them, what is your experience? How is hearing loss impacting you in your day-to-day life? So the first thing to say is what we're seeing in the data is it's actually 90% of the people we've spoke to have experienced hearing loss before any of their Lewy body symptoms. So we're having people say to us, I've had hearing problems for 20, 30, 40 years, a long time before they start experiencing the symptoms associated with Lewy body dementia or Parkinson's disease dementia. So we've got some quotes on the side here. For example, this one person was diagnosed with Parkinson's 9 years ago, but is experiencing hearing problems for 20 years. So it seems to be in these individuals in our sample that hearing loss is coming before the Lewy body dementia symptoms, but also the Parkinson's disease symptoms. So thinking about, you know, well, what's this matter? How is this impacting your life? So what we're seeing is a lot of people are reporting, as you may expect, that the hearing loss makes social activities quite difficult. So people are reporting that they feel that they're missing out, that they're not able to engage with their friends like they used to be able to. They're sat on the edge of conversations, and that's really difficult to manage. And when we talk to care partners and carers of people living with Lewy body, they kind of extend this a little bit to say, you know, I end up having to relay information a lot and re-explain everything and re-say everything. And that's enhanced even more by the cognitive problems. So the individual may be struggling to hear the conversation in the first instance and then process the information. So it's really quite a situation where some people may be feeling quite isolated and pull away from social activities. One thing that we saw as seeing as well is some people who live with Lewy body dementia experience quite severe night tremors. So really vivid, very lucid dreams that can be really very troublesome and very horrible to deal with. And some people also experience, you know, that a large sense of fear due to the hallucinations and the night tremors. And what we're saying here is some people are saying that when they're in a circumstance that their hearing loss is worse. So for example, if their hearing aids have been taken out for a period for them to be cleaned, or if they're not attuned in the right way at that present moment in time, what people are saying is it's making things more difficult. They feel more frightened. They feel less safe in that circumstance and slightly more concerned about what is going to happen. So that's kind of resonated in this quote here about the horror films. But one thing that was quite interesting is some people were saying to us that essentially when their hearing aids are in, so when their hearing is restored and they're able to hear to what we would class as a more normal level, things become easier in terms of thought patterns. They have an ability to think more concisely, think more clearly. Things just seem a little bit easier, which makes sense, right? If you're making one thing easier, then you've got more room to go through the other things. So it seems like a very logical thing, but it's interesting to highlight that the people who are living with Lewy body dementia that we're speaking to are saying that the sheer act of putting a hearing aid in is helping some of their Lewy body symptoms. So the other thing that we thought we would talk to people living with Lewy body dementia about is accessing services. So our audiology service is appropriate for people who live with Lewy body dementia. And what we're kind of seeing here is, unfortunately, a lot of people who live with Lewy body dementia or care for somebody living with Lewy body dementia find the situation of an audiology exam quite distressing for somebody in that certain circumstance. So typically when you have an audiology assessment, you go into like a soundproof booth that's quite dark, quite enclosed, and some carers are reporting that that is causing distress in their loved one. You know, putting the big headphones on in this dark enclosed booth, it's unusual. It's not, it's a very different circumstance. which may be causing and heightening distress in those individuals. Another thing that people are reporting is they're not 100% sure on the assessments. So typically a lot of the time when you do an audiology assessment, you have to press a button or indicate that you have heard a tone. And a lot of people who live with Lewy body, but also their carers, are saying, oh, you know what, I don't actually know if they haven't heard the tone or whether they've forgotten the instruction. So they've got halfway through the task, they might have forgot what they're doing and not pressing it. But linking back to the hallucinations that we spoke about before, some people living with Lewy body dementia sit there questioning, am I actually hearing anything? Or is this just an auditory hallucination that I have? So there does seem to be some issues with the services at the minute that maybe they aren't necessarily adapt for people who are living with Lewy body dementia and Parkinson's disease dementia, which need to kind of be unpicked a little bit further, because obviously we want to make sure that the services are the most appropriate for the people who need them. Obviously, the biggest issue that came out was accessing NHS services, in that most people I speak to actually have all their audiology assessments privately and are paying in excess of about £3,000 to £4,000 for hearing aids, which is a huge issue, because if you think what people are reporting that they're having their hearing corrected may be helping their Lewy body symptoms, if they can't afford that correction, then that could be reducing their quality of life based on financial status and financial provisions, which isn't fair and maybe leading to inequity in healthcare outcomes based on financial status. So that's kind of just a snapshot of what we are starting to see. Obviously, we're going to unpick this a lot more, but the evidence does suggest that hearing loss may be interacting with Lewy body dementia in some way and making things a little bit more difficult for people. So yeah, we do have some more larger scale quantitative studies to come to follow this and support the qualitative evidence. But this was just a little drop that we're starting at the minute. So thank you. I'll stop that now, I think.
Great, thank you very much to both of you. Right, does anyone have any questions for Mark and Megan? It's nice to hear specifically about hearing loss as well in that relation, and your study is still ongoing, so it's hot off the non-press yet, your findings, which is very exciting. So we haven't heard those findings before. So would anyone like to ask any questions to Mark or Megan about Lewy body dementia, Parkinson's, or specifically hearing loss? Any thoughts? You can put them in the chat, or if you want to raise your hand, that's fine as well. Right, I don't know who that is. KA 272867 has raised his or her hand. No. Okay. So Mark, I noticed your comment as well. How do you think evidence on hearing loss might feed into your services, or maybe staff training, perhaps?
I think, Megan, thank you so much. That was an amazing presentation. I've learned a lot, and thank you very much. We will chat outside of this forum. Going back to what I was saying about our referrals, we get a lot of referrals for patients that come in with confusion, and I suppose we classify those as an undiagnosed cognitive or dementia syndrome. And so, we may do the 4AT delirium score just to see whether or not there is delirium, because obviously that is an acute thing which goes away over, say, 6 to 12 weeks, and then the person will go back to as they were before. But it's important to understand through a collateral history from their loved ones whether they have noticed anything. And I think, unlike the medical model, which just looks at the here and now, what we like to do is actually ask the question 12, 18, 24 months ago, to get a better picture of whether this is something, because a person's cognitive decline doesn't just go like that. I think we found it gradually reduces. So we get a lot of information from that. But I think certainly listening to Megan's thing around hearing loss, it was really, really interesting to hear that, you know, people have said that their hearing was not was affected prior to it. So I'm going to have that conversation with Megan about how she sort of like identified this and what we can use in our assessments going forward to potentially promote and give more information, certainly to our memory service going forward. But I think it's important that we never lose fact that the collateral history is so important in getting a diagnosis, but also dealing with the person who has actually got the diagnosis. And we get that from those people that I call the experts, which are the people they live with, that love them or care for them.
Yeah, definitely. It's actually interesting that you say that, Mark. So I didn't present it on the slides, but we have had a lot of discussions when I've been speaking to people, and it's often coming out that individuals really who they wish now that when they were diagnosed with Lewy body, the first thing that they did was go and have their hearing tested. Now they know in hindsight how much it's helped them and so on. A lot of people are saying to us, we really want this to be brought up a lot more, and it would have been amazing if when we came to a service that they'd have spoken to us about that. So it would be really good, definitely, to have some conversations about that.
Absolutely. And I think it's certainly going to help us going forward, because it's something that we can put, like I said, we can put into our assessment for the person that doesn't have a confirmed diagnosis, that we can get it done. We do have a very good audiology department here at up in Wigan that we can refer into. And if the person's an inpatient and they're stable, potentially we can get them down to have that an assessment done rather than waiting for the outpatient. But if not, we can actually get that outpatient's appointment done so that it can be part of our assessment going forward.
Yeah,
so amazing to listen to your thing today. Thank you.
So some questions here from the audience, and I see one hand up as well, but what about tinnitus, Megan? Has that come up in your interviews so far?
Yeah, so it's not come up in the interviews per se, but we do see quite a lot of experience of hyperacusis. So a lot of people are reporting like oversensitivity to noise as well. So some of the times what we see is people who are living with Lewy body dementia specifically hear noises that their loved ones can't hear. So for example, if someone parks on the driveway five houses down, the individual would be able to hear it, but their loved one can't hear that. So there's an oversensitivity to noise, as well as the sort of hearing loss. So there's both sides of the spectrum experiencing that, and there is some evidence looking at tinnitus. So it definitely is more complex than it just being hearing loss, but we haven't managed to sort of dig into what that might mean yet. But yeah, there is definitely, it seems more complex than on the surface.
I never knew that about the other side of the coin, as in being uber sensitive to hearing and hearing more than other people might do.
I see.
So kind of that was raised by you, Mark, a little bit as well. So we've got another comment about why isn't this issue being promoted more through the NHS, or I suppose Specsavers or other hearing aid companies, etc. What's happening?
I have to say I don't know the answer to that. We certainly, as an Admiral Nurse Service, we deal with the patients that we see in front of us, and we use a individualized, holistic approach to our assessment. We could probably say that every referral that comes into us takes us a good 2 hours of finding out what's going on, what's the history, collateral, phone calls, etc., before we even actually go down and see the person. And we certainly look at, whether they have got hearing aids and spectacles, and it's not about this, but dentures and all those sort of things which can impact on how a person responds within the hospital. But certainly after today, this has raised something for myself, and really speaking, I got handed something about, have we got anything we want to look into in research within our trust? And it might be something after speaking to Megan that we can sort of like look at going forward. But I will certainly be having conversations with Tracy, my colleague, now about certainly asking that question a little bit more in depth. But you know, I'm not going to sit here and say I'm an expert. I don't probably know a lot more than most people do about, you know, a person with, you know, assessing a person with dementia. But this is something that's going to actually add to the information that I will be gathering going forward, and hopefully, you know, as Megan has shown, it will make a difference going forward.
Right, so already impact. I like to hear that we help raise awareness of issues, and we learn a lot ourselves, I think. Jackie, you've got your hand up.
Thank you. Yeah, I'm just thinking, Mark, and this may be something for offline, for you and Megan to speak at the next Dementia Delivery Group.
Absolutely, yeah.
Because we'll have Lambs there, Megan. So and a whole host of people, and I've now taken over that group. So I can put you both on the agenda.
Thanks, Jackie.
I'll send you details. I think it would be a good subject, and the fact that we'll have Lambs there, and there'll be a captive audience, basically. Okay. All right. Thank you.
No worries. Question for Mark, going off the hearing loss issue, but do Admiral nurses go into care homes to offer training or advice to staff regarding dementia care?
Theoretically, as an acute Admiral nurse, it's not within our remit, because obviously, as you can see from our workload, we are sort of inundated. But going back to what I was showing with regards to the virtual dementia experience, we are licensed to teach that and deliver that for 2 years. And going into this year, we are potentially going to be promoting within care homes whether or not they want to actually, you know, send some of their staff in, and we will deliver that experience for them, you know, just to try and make a bit of a difference. We do have care homes that do phone us regarding issues. Currently, there are about 450 Admiral nurses around the entire country, which doesn't seem a lot. And they work in lots of different areas. Some care homes do have their own individual Admiral nurse. I know that Belong care homes up in our locality have an Admiral nurse. But I think, you know, going forward, the more that Dementia UK, who we sort of represent as well as being employed by the trust, need to sort of like shout a little bit more about what Admiral nurses do. Because quite a lot of the time when somebody comes in and we introduce ourselves, they say, "What's an Admiral nurse?" And then as soon as we simply cut it down, "Oh, why didn't we know about you before?" But certainly we do try, and we never say no. We may not be able to go out, but we are able to sort of like, you know, I'm more than happy to send out my template slides of dementia awareness, invite people in to see us, and as I say, send out that thing to anybody that wants to come and, you know, sit in on our or take part in our dementia bus experience. But it is a bit difficult when you've got such a workload as we do here, as you know, Jackie, the previous question, you know, knows.
Yeah, we have one comment from someone in the audience saying there are some Admiral nurses in certain care homes in post, but obviously that varies hugely, and some regions or areas don't have Admiral nurses as far as I'm aware either. So yeah. Absolutely,
and I think, you know, we've made such a success of it here because there was nothing before. One of the slides, I was going to put up a blank slide and say this is what I had when I took over. I had a blank canvas. So what we see now is what myself and Tracy have put in to deliver it. But you know, that blank piece of paper is like 4 or 5 pages down now. It's blank, and then we'd like to do something different to enhance and make the service even better if we can.
Fantastic. I think that seems more or less all of the questions, but you have a lot of thank you messages for both of your talks here. So thank you, Mark. Thank you, Megan, for this joint talk. And I'm sure both of them are on social media, and you can drop them an email if you want to find out more about their research and work that they're doing. I've put a link in the chat for our next forum webinar, which will take place on the 29th of May at 1 o'clock, and we'll have another DEMCOM fellow, Dr. Sanda Ismail, who will be talking about dementia in religious communities and what we need to understand more about it. But that's all from me, and I think that's all from Megan and Mark. So thank you very much, and see you soon.
Thank you very much, everybody. Bye.